Hi, students. I thought I would just give you a short video for a few concepts from week 2. We're actually talking about anatomy and physiology of pregnancy this second week. So, refresher, fertilization. It occurs usually in the middle of the cycle. And from this picture, you can see that the ovary has released an egg and it's traveling through the fallopian tube. If the sperm fertilizes that egg, then we have a concepsis, or what we call a zygote. Okay, and the motility of prostaglandins and such helps that concepsis travel through that fallopian tube on its way towards the uterus. And in the uterus, it actually implants into the wall. And at that point, it's still considered a blastocyst. And usually by day 15, it's defined as an embryo. Okay. Implantation, it takes about a week to 12 days for that fertilized egg, zygote, to make its way down into the uterine wall. So embryo then is starting day 15 through week 8. Okay, so this is the time when all the organs are being developed. All the structures are in place by the 8th week. Starting week 9, it's considered a fetus. Okay, so during the first 8 weeks, it's called organogenesis, and I gave you some information about that. And you have a case study this week. It's called ectopic pregnancy. Ectopic pregnancies are those ovums that are fertilized and become a zygote, and they do not move and get to the uterus. They usually remain in the fallopian tube. They're outside the uterus, and that's why they're called ectopic. Just like a heart rhythms, you'll have some ectopic beats. It's because it's out of the normal conduction path of the heart. So a zygote that doesn't reach the uterus stays in the tube, and it's called an ectopic pregnancy. The baby cannot grow here. And in fact, it's very dangerous because what will happen is it'll continue to grow, and it will actually rupture the fallopian tube, and then it will die. Okay, so that concepsis will die at that point. And there's usually massive internal bleeding. Your client will have a lot of pain associated with an ectopic pregnancy. It does tend to leave some scar tissue, and sometimes we actually have to remove part of the tube. So that's the ectopic pregnancy. Now, when we have a client that comes into the office for her very first prenatal visit, we have to collect some information. She thinks she's pregnant. She missed her period. So we're going to ask her, when was the first day of your last menstrual period? That's what LMP stands for. So we use a rule, it's called Nagel's rule, and it helps us calculate when her baby's due. So we take the first day of her last menstrual period, when was it? We subtract 3 months, add 7 days, and then bump it out for a year. Okay, so if her first day of her last menstrual period was June 10th, then we're going to go back 3 months, June, May, April, March. Okay, May, April, March. So add 7 days, May 17th, 2022 would be her due date. If her last menstrual period, the first day was June 10th, it's going to be May 17th, 2022. Okay, that's how we calculate approximate due date. It's pretty accurate. So you also need to learn about the symptoms and signs of pregnancy. So we use the P's. Okay, so if your client comes into the office, she has symptoms. She's experiencing something that we can't measure, but she explains that she's been nauseous and vomiting. Her breasts are tender. She's missed her period. That's what amenorrhea means, okay? She's going to the bathroom all the time, frequent urination, and she might even be feeling the baby move, and we call that quickening. That's usually not until into the second trimester, between 16 to 20 weeks or so is when she feels first movement. If it's her first baby, sometimes it's earlier for a woman who's had more than one baby. So that we call those presumptive symptoms of pregnancy because we can't measure them, we can't necessarily see them, and so we're presuming she's pregnant. Now, if we do a pregnancy test in the office, in other words, the HCG test, this one, if it is positive, then we're going to make the statement she's probably pregnant. But there are certain medications that can make the HCG test positive too. Okay, like anticonvulsants, those kind of medications. And if she's on birth control, it might throw things off. Or she's been going through fertility treatments. And then we also, as I'm examining her, I can say, yeah, you're probably pregnant. And there's other things that I can see and measure. And these are the probable signs. Chadwick's sign is a bluish color to the cervix and to the vaginal walls. The increased blood flow in the area, it's more congested now that she's pregnant. And so it tends to be a blue tint. And then Goodell's sign, should put a sign in here, is when I do my bimanual exam, I notice that the cervix is softer. It's softer, okay? And the ballottement is just a vibration of the fetus. When I palpate and I push up on the cervix, I might be able to feel the baby bounce. It depends how far along she is, okay? And there's others, probable signs, but these are the most important ones. So the uterus in pregnancy relaxes because of hormones. The progesterone hormone causes the uterus to relax a little bit. The progesterone also causes muscle ligaments to relax, especially in the pelvis. And so the uterus tends to flop over. Okay, it's called the McDonald sign. And that narrowing of the lower uterine segment before the cervix is also soft. And so that's when that flops over on top of the bladder, that's Hagar's sign, okay? But the only way we can tell our client that she's positively pregnant is if we do an ultrasound and we see the fetus, or we see blood flow, okay? Or maybe we have a Doppler and we can put it on her pelvic area and we can find the fetal heartbeat. So if we're able to identify a fetal heartbeat, we can tell her for sure she's pregnant. And if she's really far along and she's got an expanded belly, I can put my hands on her belly and I can feel movement of the fetus. That's another positive sign, but that's the only way we can tell her for sure she's pregnant. If we see the fetus, if we hear the fetus, or if I place my hands on her belly and I feel the baby moving, okay? So going back to embryology, we're going to be talking a little bit about exposure, teratogens, or exposures that can damage a baby. So during those first 8 weeks, during organogenesis, this is the most vulnerable period for congenital anomalies. If the mother has had a lot hyperglycemia, high levels, there might be some missing limbs, okay? If the mother smokes cigarettes, her baby's going to be smaller. If the mother is on medications that could damage, like if she was not immune to rubella and she contracted rubella during that first trimester, baby's going to have some damage, heart and probably ear damage or hearing loss. So that's what we mean by teratogens, is anything that baby is exposed to during those first 8 weeks in particular. Okay, so another concept we'll talk about is gravidity and parity. So it's just a way of categorizing the obstetric history of our client. So we use the categories GTPAL, so gravida and para. So the G in GTPAL is the number of times that she's been pregnant, no matter what the outcome was, whether it was a preterm, post-term, abortion, whether it was anything, stillbirth, it doesn't matter. She got pregnant. How many times has she been pregnant? Okay. Then how many of those pregnancies were delivered between 37 weeks and 42 weeks? Those are the number of T's. And in any pregnancy that was delivered after 20 weeks and before 37 weeks are considered preterm. And then abortions are any pregnancies lost before 20 weeks gestation. The term gestation means pregnancy, okay? So 20 weeks gestation. Less than 20 weeks is called an abortion, whether it was spontaneous or medical or induced, okay? So gravida para is pregnancy and then delivery. So let's take an example. So you have a woman in the office. She's pregnant currently. She's already delivered 2 full-term babies. She's also delivered a preterm baby. She's had 2 spontaneous abortions and 1 stillborn at 28 weeks. Okay, so let's figure this out. How many times has she become pregnant? Or has she conceived? Okay, well, she's currently pregnant. So that's 1. 2 full-term deliveries, that's 3. 1 preterm delivery, that's 4. 2 spontaneous abortions, that's 6. And 1 stillborn, that's 7. Okay. Well, the stillborn is considered a preterm delivery. Okay. It's at 28 weeks. So it is between the 20-week and the 37-week. Okay. And so it's, even though the baby was not alive when it was delivered, it was still considered a pregnancy that reached parity, which is 20 weeks. Okay, a parity is a delivered fetus past 20 weeks. That's what parity means. Okay, so how many of those were full-term babies? Well, just 2. Okay, how many were preterm? Well, she had 1 preterm delivery and 1 stillborn at 28 weeks. So she had 2 preterm. Okay, and then she had 1 stillborn. So her gravidity is going to be 7, G7. I'll show you down below how we do it. So the G is 7, okay? The T is 2, so I'll put a G here. Full-term babies, right there, she had 2. Preterm babies, she had 2. Abortions, she had 2. And then the last, the L, stands for how many living children? Well, she has 3 living children. Okay, because she hasn't delivered 1. She had 2 full-term deliveries and a preterm delivery. Okay, so those 3 pregnancies there. The stillborn was not alive, so we can't count that as a living birth. She has only delivered 3. Okay, she's had a lot of losses. All right. And then the important functions of the components of a pregnancy. Okay, we have amniotic fluid, the placenta itself, and the umbilical cord. So the placenta is very important. And to understand the placenta, you have to understand the physiology. Okay, well, let's start with the amniotic fluid. Why do we need fluid around a baby? Well, we need the baby to be able to float freely in order to move around, to grow, and so the cord doesn't get caught and impinged. It helps keep that baby at that ambient temperature of mother's body, so it stays warm. Okay, that's the most important. And it protects that baby from any, it's like a shock absorber. Okay, so that is all that the amniotic fluid does. It's the safety factor in the pregnancy, you might say, the safety component. You could say that. Safety component. The placenta, its function is gas exchange and nutrient exchange. So placenta develops and is mature by week 12 of the pregnancy. Okay, it's mature then. It's going to provide the hormones that the pregnancy needs to grow and to function and to complete. Okay, so at 12 weeks, it produces the progesterone. Prior to that, it was the corpus luteum and even the ovary. Okay, so the placenta is called our exchange organ because the maternal blood vessels and the fetal blood vessels are interfacing. Okay, they're butted up against each other so that the oxygen from the mother's blood can diffuse into the fetal capillaries. Okay, the carbon dioxide from the fetal blood can then be returned to the mother's circulation to be reoxygenated. The maternal capillaries also have nutrition that the fetus uses to grow. And then the fetal veins have, or the maternal veins will collect the waste products, the carbon dioxide and the nutrient waste products. So that's the exchange. So the umbilical cord itself carries those three vessels. Okay, so the only job that the umbilical cord has is a channel and to protect those blood vessels. So the baby has one large vein, and the vein is what carries the oxygenated blood. The little two arteries carry deoxygenated blood and waste products back to mother for exchange. So that's the only function of the umbilical cord. It's got some jelly surrounding it inside the cord around the blood vessels to keep them moist and cushioned to prevent trauma to the cord. And so that's the only thing that it does. It's the pathway to the placenta and back. So that the most important thing to recognize here is that the placenta is doing all the work. Okay, so adequate blood flow to the placenta from the uterine muscle, the uterine blood vessels is very important to keep the placenta functioning. Okay, so just some other things I want to talk to you about. Cardiovascular changes. Cardiovascular system in pregnancy works very hard, keeping adequate blood flow to that uterus for the placenta and the fetus. So in order to do that, the mother's body has to produce more red blood cells. So she's got her hemopoietic system working hard to produce more red blood cells. And then the plasma volume has to nearly double So she's got a lot of extra intravascular volume circulating through her heart, liver, and through her kidneys, and through the uterus and her brain. Okay. So she has an increased cardiac output. In other words, her heart's going to beat a little bit faster, and it's going to be the volume that it's pumping is going to be greater. So that's what we call the cardiac output. Because there's a lot more plasma than red blood cells during pregnancy, it's like the red blood cells are diluted in the plasma. It looks that way, okay? And we call that a physiologic anemia or a dilutional anemia. It's not necessarily a true anemia, okay? Also, about the cardiovascular system, there are high fibrinogen levels. In other words, she's going to be clotting a lot easier. Okay, so she's going to make fibrin clots a lot quicker than she would if she wasn't pregnant because of the increased fibrinogen. Also, she has decreased peripheral vascular resistance. In other words, the blood vessels in the periphery. So the blood vessels in the arms, the legs, and in particular the pelvis are relaxed. Okay, they don't have that resistance because that allows for more blood flow in the area. Okay, so it's almost a congestion. The uterus can actually have a whole liter, 3 liters of blood by the time she reaches full term. That's a lot of blood. Okay, and because of the decreased vascular resistance, the congestion of blood, and estrogen does this. Estrogen helps blood vessels grow and to dilate and to relax, to provide adequate perfusion of the uterine tissues. And because of that, she might feel lightheaded, pooling of the blood in the lower extremities and the pelvis, fainting. She might have some nasal stuffiness because of nasal congestion. Okay. And then there is a term called supine hypotension, and we'll talk about this in class too. If a client is in her second trimester, and as she progresses along in her pregnancy, when the baby and the amniotic fluid are of significant size, if she lies flat on her back in the supine position, that baby can actually compress the inferior vena cava and maybe even the aorta. And it causes hypotension or blood pressure drops because the blood flow from the heart or the blood flow in the inferior vena cava and the aorta are slowed down. So that's why she might feel lightheaded. Okay, and her blood pressure will drop then. And then when the blood pressure drops, that means that the uterus is not being perfused well. And if the blood flow to the baby is reduced, then it can compromise the oxygen level of the baby. The baby relies on the oxygen in mother's blood to survive. Okay? Not on its own lungs. Its lungs are non-functioning until birth. They're mature around 35 weeks, but they don't actually function before delivery. Some information about nutrition in pregnancy, the most important stuff, pica, usually a sign of iron deficiency anemia. It's eating things that are not meant to be eaten, like starch, dirt, chewing on ice. Those are all pica. It's just a sign of iron deficiency anemia. So we can supplement her with some oral iron throughout her pregnancy. Folic acid is B9 vitamin B9. Okay, folic acid is a necessary vitamin to cause growth for the fetus. Inadequate levels of folic acid in the body prior to conception and then during those first 8 weeks of organogenesis can reduce the closure of the spinal cord. Okay, the neural tube. The neural tube is where the spinal cord is developing, and has to completely be covered and closed in within the vertebrae, within the tissues. And if there's not enough folic acid, it won't be able to do that. And it's called spina bifida or a neural tube defect. Okay. So one thing about our pregnant adolescents, they are young. An adolescent is below 19 years old. So 18 and under, considered an adolescent still. And, they're still growing. So the demands, if they get pregnant, the demands on her can be huge. So she might not be eating enough or the right things. So it's really important that we evaluate our adolescents as far as nutrition, what they're eating, and give them some guidance. Keep an eye on their weight and their baby's growth. Okay. Adolescents tend to have low birth weight babies. That's what LBW, low birth weight. You need to know the normal BMIs. Okay. So a normal BMI, an ideal, is 18.5 to 24.99. Okay. Pyrosis is heartburn. During pregnancy, the GI system slows down. Okay. So food will sit in the stomach a lot faster. And it's not uncommon for a woman to become constipated. So we just encourage them to get some exercise, drink a lot of fluids, and eat a lot of fiber. Okay. And later on, nausea and vomiting in pregnancy, sometimes associated with those high HCG levels. But if it gets severe and she's not keeping anything down and she's losing a lot of potassium, and we'll be talking about that more in the high risk week 5. Hyperemesis gravidarum is having low potassium because she has been throwing up a lot. Okay, so I also will be giving you a chart about what food groups contain which nutrient. So B12, iron, folic acid, vitamin K, and then we'll learn about phenylalanine hydroxylase deficiency, which is the inability to metabolize certain protein, that protein. Phenylalanine is a protein in our body, and people with this disease, it's a genetic disease, cannot digest that protein. So we'll learn about that later. Testing during the antepartum period. Everybody is routinely tested for carrier screening. Let's see here. Let me find it. I don't have it in this set. So carrier screening, and then other antepartum, the triple test, or the AFP test. We'll be talking about this week. So the carrier is about genetic screening, a history. And then the triple test is assessing if there's a risk for Down syndrome or neural tube defects. So we'll talk about that. All right, let me show you one more thing. The circulatory system of the fetus is different than an adult. Okay, so we know normally that the blood comes into the right atrium from the inferior vena cava and the superior vena cava. Okay, all the venous blood will come into the right atrium. Normally, it then is pulled into the right ventricle, up through the pulmonary artery, and goes through the lungs to pick up the oxygen and get rid of the CO2. It returns through the pulmonary veins back to the left atrium, oxygenated, back through the left ventricle, and then up through the aorta and out through the rest of the body. But a newborn doesn't use the lungs for oxygenation. The blood coming in from mother comes in by way of the liver. It bypasses the liver. Some blood flows through the liver, and that's called the ductus venosus. So not a whole lot of blood flow in the liver. And then it reaches the right atrium. Okay. Instead of going to the right ventricle, some of it does go that way, but the majority of the blood, highly oxygenated blood, actually goes through into the left atrium. So the opening between the right and the left atria is called the foramen ovale, and is well oxygenated so that it can go directly up through the aorta. And since the blood that comes into the right ventricle, the small amount that does comes up through the pulmonary artery towards the lungs. There's a shunt there. Some of the blood does go to the lungs, but most of it goes through that shunt into that aorta. And there's a picture of it there. You just have to study the picture, okay? Because there's no exchange that's taking place. So we don't need a lot of blood to flow into the lungs. So it bypasses the lung, goes to the aorta. Still pretty good, pretty well oxygenated. Okay, so you have the ductus venosus, the foramen ovale, and the ductus arteriosus. Okay, remember, the lungs are not functional during fetal life. No gas exchange. Placenta is actually performing the gas exchange for the baby. Okay, so you just have to kind of look at this picture for a while to understand it. Okay, I believe that's everything I was going to talk to you about right now, and I will see you in class this week.